So I don't know how much experience everyone has with pediatric cardiology, but I'm going to go over a big chunk of what you guys may see, especially in the neonatal part of it, but then we're also going to go through other things for older kids too that you might run across if you go up to Thompson to pick up a kid and those types of things. There's not just babies that have heart issues that we need to know about too. So when I'm doing this, I want this to be kind of chilled, open. If you have questions, please feel free to ask. And I want Todd and Dave, and if Ainsley's going to be here too, anyone to put in your experiences, because I'm just talking about the heart stuff. You guys know more about with the transport stuff, so I think it's nice if we can kind of collaborate.
So Amber's point of presentation, and we talked about this, was this is what you know what you're dealing with. When you go up on transport, you're not going to know what you're dealing with. You'll know you probably have a cardiac defect and you need to treat it, but it's really irrelevant, really, what the actual defect is.
Yeah, exactly. Because no one's going to know until you do an echocardiogram, right? So there's some clues as to what we need to do with what we're presented with. So we're going to go through that. Okay. Does anybody have experience with cardiology at all? Some? A little bit? Okay. Hopefully it won't be too dry. Okay. So some potential cardiac patients can include cardiovascular collapse, ductal dependent lesions, which most of you will be experiencing when you're doing the neonatal transport, congestive heart failure, cardiomyopathy, arrhythmias, tetralogy or TET spells, obstructed shunts. So when we put in shunts surgically, those shunts may not grow along with the child, or they become smaller or kinked, so they obstruct. And then any post-operative complications. So we have two different types of heart disease. We have congenital heart disease, which they're born with, or acquired, which they acquire along the way. So under congenital heart defects, we have alterations in fetal cardiac embryology, and they're ranging from insignificant to life-threatening. It's all about timing of the presentation, depends on the lesion, and about 1% of all live births have a congenital heart disease. So that's kind of big in a sense when you think about it. And most common heart defects are VSDs. They basically make 50% up of all the heart defects. And there's about 40 to 50 different combinations of heart defects. And apparently in Manitoba we have the most weird and wonderful combinations of heart defects. So once you think you've mastered a certain lesion and then they throw in a few different alterations to it, sometimes my head still spins after 15 years of doing this. So it's not an easy grasp kind of a thing to comprehend sometimes, because they start adding in all these different types of things. So you have a combination of different 2 or 3 times lesions when you have some of these kids, and Manitoba seems to produce them for some reason. I don't know if you guys have experienced that too, but yeah, they're kind of weird looking ones. So acquired heart disease, basically it's acquired through the lifespan. They're technically saying it's adult focused, but they'd include rheumatic heart disease, endocarditis, Kawasaki's, myocarditis, and cardiomyopathies. So clinical presentation of congenital heart defect. So you may or may not see cyanosis, reduced pulse oximetry, so lower sats, respiratory distress, increased work of breathing, head bobbing, congestive heart failure, cardiogenic shock, heart murmur, arrhythmia, frequent respiratory infection sometimes is a clue for our little older kids that haven't been diagnosed with certain defects, poor growth as well, failure to thrive, and differences between upper and lower limb pulses and blood pressure pulses, or blood pressures. And we all know it's very hard to get a blood pressure on a baby, never mind trying to do 4-limb BPs. So what we're going to do is we're going to do an assessment of the cardiovascular system. We're going to observe. So we're going to look at the respiratory effort. How are they breathing? Are they working hard, or are they nice and chilled? Any feeding difficulties? Have they been able to gain weight? Are they throwing up all the time? Color, are they pink? Are they perfused? Are they warm? Any signs of systemic perfusion, clubbing? Okay, some of our cyanotic kids that have not been treated or later on in life will develop clubbing. I don't know if anybody's seen that on their fingers and toes. And then upper and lower limb SATs as well. So cardiac rhythm we're also going to look at too to see if there's something going on with that. Doesn't necessarily mean you might be listening to the heart and you can hear the heartbeat. It might be fast, it might be too slow, it might skip a beat. So we want to look at that as well. And then forelimb BPs as well. We want to listen to the chest sounds, the heart sounds. We want to palpate. We want to feel pulses. We want to feel them centrally and peripherally. Any thrills. And we're also, not very often do we know how to check liver size, but that's kind of the end stages, kind of heart failure. The liver size starts to get quite big and boggy and start pushing up. Okay.
Yeah, so I know in a lot of our scenarios we do check for liver, but it is a late sign of cardiac failure.
Yeah, but that is one part to look at too, if it's for heart as well. And then we have some diagnostic tools that we can look at to help us diagnose things. So we can see a chest x-ray, so we can see if the heart is enlarged, if it's pushed over to one side. Sometimes we can even diagnose a tetralogy of Fallot on a chest x-ray because the heart looks like a boot shaped, so that's another way that we can look at things as well. Or we can take the chest x-ray and see the heart looks normal size, it's in the right position, but maybe it's the lungs, right? So you might see differences in changing in the lungs. We can do EKGs to see what heart rhythm is doing. We can do an MRI. Of course, ultrasound, the echocardiogram, gives us lots of information. In the clinic, we can do stress tests, exercise testing. We do Holter monitoring to do rhythm for 24 hours. And we also do heart catheterizations to actually see exactly what's going on in the heart, the flow of the blood, and if there's any blockages or holes or anything like that. And then we can do nuclear medicine tests, MUGAs, MIBs, lung perfusions, and first pass. So that's kind of what we do in our clinic sometimes, is order all those extra things to see what else is going on, or to kind of continue on our assessment to see how management is doing. Any questions so far?
What are thrills? Sorry.
Thrills, you can actually sometimes feel them. It's like a vibration.
Okay.
Yeah.
Just like in the actual chest, it just.
Yeah, like if you can actually put your hand on, feel the chest, and you can feel the thrill. Yeah. And sometimes that's when they're really hyperdynamic, so you can like just everything is pounding away. Okay, so we're going to organize congenital heart disease into 3 different categories, and we'll go through each of them separately. But the first one would be increased pulmonary blood flow. So that's increased flow to the lungs, okay? So you are going to be looking at supporting congestive heart failure, okay? You've got the next category is decreased pulmonary blood flow, okay? So you're not going in, you're having blood flow that's not going very well to the lungs, okay? And so we'll have to actually intervene in those instances, either surgically or in the cath lab, and then we're aimed at increasing blood flow. And then we're also looking at the PDAs for certain ones too, right? Because that's another way of keeping blood flow as well. And then we have obstruction to systemic blood flow, so going back to throughout the body after the oxygenated blood gets all pumped around. And those ones we're going to aim at supporting heart failure and poor ventricular contractility.
Actually had a baby in NI that had come in, normal, like no antenatal history or anything, was fine, started to have DSATs, came into the unit, color looked awful, started to go downhill, we intubated, put art line in, and we're looking at so we had the art line in, so we're looking at we had pre and post SATs on, so the art line and the pre were measuring for heart rate, but the post was like way off, and the BP was like so low, it was like, the mean was like, I think like 28, so the attending had just left, and so I called him back and said, something's wrong, Like something's not right. Like the art line should be the one that is measuring the most, but they're not all correlating.
Yeah.
So we came back in, and then when we had turned the baby, there was like it looked like a bruise, but it was actually necrotic tissue on the thigh.
Oh.
So he got very hard to come in right away and do an emergency echo, and the baby had a congenital heart defect that was not operable. I guess one of the branches to the heart wasn't connected properly, and it couldn't be fixed.
Okay.
And so we were trying to like perfuse dead tissue like the whole time, like we were bolus after bolus and like bicarb, because the bicarb was like 2, and it was, yeah, and that kid passed away like by 7 o'clock in the morning.
Okay.
Because there's no blood, like
Yeah.
there's no blood flow happening
Yeah.
whatsoever.
Yeah.
And
So it was already, you were already starting to see signs
already, and that was
Yeah.
probably like, I would say 6 hours in,
of. Yeah.
and it was
Yeah.
already like necrotic spots that were happening.
Yeah. It's amazing.
But just knowing that like something was wrong, because I'm like, that should be right.
Yeah.
And these are not correlating. Like it was the post-heart, it was like, everything was just not
Yeah.
adding up.
Yeah. And that's intuition too, right? And it's just like,
Yeah.
yeah, this is not making sense.
Yeah.
Absolutely.
That's
Yeah.
why you know what's supposed to be right, and
Yeah.
something's off.
Yeah.
But you can't tell. Like we didn't, like
You can't see, right?
there
You
was
don't
no
have
murmur,
enough. Yeah.
There was,
Yes.
you know what I mean? It was
Yes.
just,
And we'll talk about not hearing
right?
murmurs.
and
Yeah.
no antenatal history, because they missed it
Yeah.
on
Yeah.
ultrasound,
Yeah.
right? So,
Yeah.
didn't really know what was happening, right? We
Yes.
just couldn't get stabilize this kid at all. Like we were just doing everything, and
Yeah.
it didn't really matter what we did.
What you did, it
because
wasn't working.
It
Yeah.
wasn't gonna work. Right?
Yeah.
So,
Yeah.
And I guess the other teaching point out of that story, that is that even though the fetal ultrasound is normal, they sometimes miss some things.
yeah, and I've seen
Yeah.
that like a lot.
Yeah.
Where they miss,
So,
miss
It's
Yeah.
not 100% diagnostic, those fetal ultrasounds.
Okay. Okay, so neonatal presentation of congenital heart defects. So you've got the cyanotic, non-ductal dependent, which makes up about 15% of the heart defects. In that category, we have the tetralogy of Fallot, truncus arteriosus, TAPVR, and Epstein's. Cyanotic ductal dependent makes up about 9%, and we have TGAs, tricuspid atresias, pulmonary atresia with intact ventricular septum, and critical pulmonary stenosis. And then we have left-sided obstructive ductal dependent, which make up about 18%, which is quite a big number there. I just
Chunk.
noticed that. Yeah, it's
That's a
a,
big
it's a
chunk.
bigger chunk than the, than the non-ductal dependent ones. So we have coarcts, critical AS, interrupted aortic arch, and hypoplastic left heart syndrome. And we're going to go through all of those too. So, increased pulmonary blood flow. It's our first kind of stage here. So, the physiologic effect of most common heart defects, there's the PDA, the ASD, the VSD, and the AV canal. Those are all the nice, pretty ones. I find them the nice ones, right? Because they're easy to correct if you need to. Some of them may or may not cause any problems. We may live with some of them and not have to do anything, or they're pretty easily fixed. And then once they're fixed, most likely you don't need to do anything else with them. Okay. So underlying principles in this category. So blood flows to the path of least resistance. That's kind of how everything kind of goes in life, right? The left side of the heart has a higher pressure, while the right side of the heart has a lower pressure. Okay, and we know that because the left side has got the main pumping chamber, and it's got to go to the whole rest of the body. So there is effect of increased pulmonary blood flow depends on volume of flow. Okay, so these make up about 50% of all the heart defects. So increased pulmonary blood flow. So here's our VSD. You can see the hole in the bottom chamber of the hearts. You can see the mixing of the blue and the red blood. So that means that more blood has to keep going back to the lungs to get fresh oxygen put in and then pumped back to the rest of the body. So that means then the lungs are actually working harder, and you're going to show effects of some heart failure, breathing faster, not very much weight gain. They tend to breathe faster, I said that already, weight gain, those types of things, so their failure to thrive. Okay? if it's
They're
a
poor feeders.
moderate
They're poor
size.
feeders also, right?
They're poor, yeah. They tire out basically. They don't get their full feeds in, or they sleep longer because they just don't have enough energy. I don't know if you guys have ever tried sucking out a bottle. It's exhausting, right? It's hard work, and then they also have small airways, so they have to breathe. And if they're breathing faster, you can see that it just kind of goes downhill from there.
And then those kids usually choke, so we put them on a SoFlo, and then it's even harder.
Exactly. Okay. And then again, the ASD doesn't cause the failure effects that a VSD would, okay? So you have the hole in the upper chamber, you're still having the mixing of the blood, but it's not as bad as what a VSD can be, in the sense that if a child has an ASD and it's a moderate size, we don't actually fix those kids until they're about 3 years of age. We let them go that long. The one thing with ASDs is they get frequent respiratory infections. So sometimes that's a clue on if they were never diagnosed, that they may have an ASD as well.
Why is that, I wonder?
I don't know, to be honest with you. That is a good question, but that's just in my experience. We find ASDs are, they get frequent respiratory infections. And it's interesting, like it's a simple procedure to close it, it's just a patch closure, but we always find that we get the most complications of pericardial effusions after having ASDs repaired. I know, it's quite interesting. We're always like, oh, an ASD, but it's like, yes, that one's going to come back with an infusion, right? So.
And when they do put a patch in at 3 years old, are they then having to put in a bigger patch when they get?
Nope, it's closed. After that, it's done.
Oh, okay.
Yeah, so they sew the patch on it, and then your own cells cover that patch, and it just becomes part of your body. And if you've got a good surgeon and they close it completely without any leaks, then we don't have to. We still follow them every once in a while, but definitely not as frequently. Same with the VSDs as well. We sew a patch on them as well. Sometimes, depending on where the VSD sits in the ventricle, the way it's angulated, sometimes when they sew the patch on it, they can't quite get everything, so you may still end up with a residual patch leak, but those ones shouldn't cause any problems, okay? And then something else, even like with most of the surgeries, and we'll go into it in a little bit too, when you're also sewing those patches on, that's close to the AV node as well, so sometimes we end up actually putting the child in heart block and having to have a pacemaker post-surgery.
That's one thing I never understood when these kids have septal defects and they don't have arrhythmic, because that would interrupt their conductive pathways.
As long as they're not anywhere near the AV node, and that's kind of where that area is. So it's, I mean, obviously the surgeons know structurally where it is, but sometimes in order to actually close the hole, you trading one thing for another, right? So.
And that's just a Teflon patch?
You know what? I don't know exactly what they're.
Generally, your body's not rejecting it.
No. And our illustrious PDAs, they serve a purpose. Sometimes we want them, sometimes we don't. Technically, they're supposed to close after birth. Some do not. In general, without any other structural heart defect, a PDA that's not closing or is quite big in the baby can cause heart failure. Okay, so you're going to see all the signs of increased work of breathing, failure to thrive. So we look at seeing if we can close on its own or trying to treat it, and if not, then it needs to be surgically ligated as a baby. If they're a little bit older, we can actually do a heart catheterization and put a plug or a coil in there and actually stop the blood flow going through.
Been seen a lot. The trend in NICU has been not to actually do the closures. Like we'll have babies that have PDAs and they'll do like Indo, ibuprofen, Tylenol,
they try and treat them
they'll do all these
medically
courses,
first,
and then if they don't close, they still don't surgically. They just like, oh, well, they'll outgrow it.
It depends. Depends on the size. It depends on the baby. Yep,
Yeah.
exactly. If they're failure to thrive and that PDA is causing the issue, then yes, they will
Yeah.
get rid of it.
So you're actually talking about a PDA in a term baby or a PDA in all babies?
In all babies, in the sense, I mean, they could be neonatal, have nothing else going on, right? And
Because
then
the
in the
PDA
end,
families have a reason because they don't have the things to close them. Right?
Yeah.
But
Yeah.
a term baby born with an open PDA.
can cause.
Yeah.
But then sometimes we love our PDAs and we want them and we want to keep them open,
Yeah.
right? For if there's other issues in the heart that we don't know of. So it's a love-hate relationship sometimes.
It is.
Okay, a canal or AVSD. You've got two components, basically an ASD and a VSD. Depending on if it's a big one, you might have a big ASD and a small VSD. You might have just one big hole, and it works with the valves too. Okay, so that's another part of it. So you have different types of AVSDs. But basically you've got mixing as well, so you're going to have the failure symptoms as well. These don't have to go out for surgery right away if it needs to be closed. Usually wait for at least a good 6 months if we can maintain them without having heart failure symptoms, as well as a VSD as well. We like to try and get them as big as we possibly can before they have to have surgery. Any questions on those yet?
Those are more common in Downs babies.
They are, yeah. There are genetic correlations with some of our heart defects as well, but yes, Downs babies are very more susceptible to canals. Yeah. So other lesions that cause increased pulmonary blood flow. Okay, so you've got the truncus arteriosus. You have the double outlet right ventricle. Kind of looks like a tet. We'll kind of go through those as well. AP windows and unbalanced single ventricle physiology. So basically, some of these kids are okay for a while, and they will eventually start to show some signs of failure as well. And when at the top one it says when the PVR drops. So we know as with babies, their pressures in their lungs are quite high, and it takes about 3 months after they're delivered for those pressures to actually fall, nice and normal to what we walk around with. So at that time, in 3 months of age, is kind of when we start to see some of our kids go into these failure symptoms, because the PVR drops and then the shunting gets bigger, right? Because we're doing the flow of least resistance. So you'll see that more signs of failure start to happen around 3 months of age. So here's a double outlet right ventricle. So you can see there's a big hole in the ventricle, and basically it's almost like both of them are coming off into one. Can you see that, both of them? The pulmonary artery and the aorta. So you have one kind of big hole, and it looks like it can affect the valves too sometimes, but those valves look pretty good, but it's kind of big one hole there. And then the truncus as well is a single artery that originates from the heart just above the VSD. So you can see the mixing of the blood, okay? And you can imagine once the pulmonary pressures start to fall, you're going to get more mixing back and forth, okay?
Oh, Amber, if you want to point things out, the mouse actually works on the right hand side.
Oh, okay. Oh, yeah. I'll leave that there for now. Okay, so congestive heart failure, we kind of went over some of the things, but we'll redo it again. So basically it results when the heart is unable to pump an adequate amount of blood to meet the body's needs. So congestive heart failure refers to a group of signs and symptoms. And we can see these things in regular babies that don't have heart, right? So it's kind of tricky. You kind of have to see what the big picture and everything is together, right? So you have tachycardia, you have tachypnea, you have a big liver, you're having failure to thrive, feeding difficulties, and diaphoresis, especially with feeds. So sometimes when we teach our families to watch for signs, when babies are feeding, when they're in heart failure, they'll actually have beads of sweat on their foreheads. Okay, not because we've wrapped them up in 50 million blankets and stuff, but because they're having to work that much harder. Heart failure may be due to unrepaired defects that cause increased pulmonary blood flow, or obstructed or leaky valves. narrow blood vessels, shunts, arrhythmias, cardiomyopathy, endocarditis, and myocarditis. So now we're going to do a little case scenario. Except you guys have the answers. So you have a 3-month-old that's brought to emerge because of respiratory distress. It's irritable and has poor feeding. It's been progressive over the last 3 weeks, and in triage, the assessment is heart rate's 170, rests 80, BP's 80/40. We have a loud systolic murmur. We have normal pulses, the liver is 4, and our cap refill is about 2 seconds. Okay. They do a chest x-ray. Looks a little wet. I know. I mean, we're not here to know how to read x-rays, but it looks a little wet, right? So basically, it is, or it could be, a VSD or a canal. Okay. And we're doing a left to right shunt lesion. Okay. And what are we going to do? So usually what we will do in cardiology is start diuretics, because obviously they need to decrease some of that extra blood flow that's going to the lungs. They get pretty wet, so we start with Lasix. Sometimes we can add spironolactone as well, but usually we start with one, and if we find it's not doing well, then we'll start with a second layer as well. These kids, we want to avoid excess oxygen because it's going to decrease that PVR and increase the shunt back and forth. Okay, we always want our kids to have perfect sats, right? In cardiology, sometimes that's not a good thing, right? Sometimes oxygen is not your friend with cardiac, especially with cyanotic. But with kids that are not, like this is not a cyanotic picture, but if we keep adding more and more O2, then we're actually going to cause more shunting back and forth, and you're going to see more of those failure symptoms. Okay, you're not actually helping them. We optimize caloric intake, and obviously they may require admission for to optimize their medical therapy. So medical, heart failure management, comfort and rest, nutrition, we might increase their calories, fluid management, sometimes medications, we might have to actually go to inotropes, and then obviously diuretic or an ACE inhibitors to improve function and contractibility. Surgical heart failure management, we might do what we call palliation. Doesn't mean that we're letting them pass away. It means we're palliating them until their next stage. They may, so let's just say baby has a huge VSD, but is super small, not quite ready to have a full repair. What they might do is actually might band the PAs. So they put a little, like a elastic band around it to make them a little tighter, so that blood flow isn't going as much, so that they can gain weight, they can grow, they can thrive, they can get a little bit bigger before we actually do the repair of the baby's heart. So it's not that we're not letting them live for that. And then obviously corrective, so we're going to do a repair and prevent pulmonary vascular disease. Because that's another fun thing too. Having all those pressures being so high all the time can cause pulmonary hypertension, and that's another scenario we don't want to do, right?
The only way you could make the diagnosis is with an echo.
I mean,
So if this kid came to emerge and decided you're wet, whatever.
You would still get cardiology consult, right? We would come in and do our things, but these are some of the things that you may see, right, when a kid presents, yeah. But it could be anything too, right?
Right.
Yeah.
So the oxygen could be like this.
Well, and that's the thing, because a lot of kids, especially this time of year, right? It's viral season, so they're coming in. We think right away that, like it could be respiratory. But yeah, and it could also be a undetected lesion, right? As simple as a VSD, but in heart failure because of that. But it looks like a respiratory picture from viral, right? So yeah.
But then the SAT goals could be kind of tricky.
We just don't know.
Keep them lower,
Yeah.
like on the lower end, like 92 or something, as opposed to.
Yes. Yeah. Yeah. I mean, we'll see at each lesion we kind of accept a certain type of range for their SATs. Technically VSDs and that should have normal SATs, right? They're not a cyanotic, right? So if their SATs are lower, it could be because of a respiratory illness, but they should have normal SATs. But you're also going to listen. Is there a murmur? You should hear murmurs in VSDs and canals, PDAs, aortic stenosis, all those types of things. You should be able to actually hear the murmur as well. So that's another clue that you add in. Oh, I hear a murmur. Okay, we should consult cardiology because, right?
But then again, on a transport
On a transport,
situation, you don't know if it's a cardiac or a respiratory
you don't.
issue because the symptoms are almost identical,
Yes,
right? So this
It's
is
tricky.
medical control consultation is crucial because you're going to have to decide whether you're going to treat this as a cardiac or a respiratory until you get back to health sciences.
Mhm.
And then they can consult cardiology.
Yeah.
So our route would be through medical control, they can consult cardiology, like if we're.
Well, and they'll give you direction how to go if you can't decide if it's if you suspect it's a cardiac, you want to talk to medical control because if you think you're going for a respiratory issue, ends up being a cardiac issue, that's a whole different ballgame, right? Because then you treat it differently, right?
Yeah. I mean, I wouldn't suspect you guys
No.
would be coming and finding out a kid with VSD kind of a thing. This is just kind of what we kind of look at and how we assess. Yeah.
But what we have to do is we have to take what information you're giving us and apply it.
Yes.
Either or.
Yeah.
But we can't make the decision in the field.
No.
Get the kid back and deal with it here.
Yeah.
But you would hear murmurs, so that's something.
Yes.
Yeah, so that's an important part of your assessment,
Yeah.
right?
That's why we're always looking at all the things.
Yeah. You're putting a big picture together.
I mean, a kid could be tachycardic, but he could have a fever, right?
Right.
Doesn't necessarily mean they have an arrhythmia. So there's, we have to start looking at the list of what everything is and start, You're being a detective, right? Okay. So this is kind of what we do. It's just a little extra information. It's nothing that you guys need to worry about for the transport stuff, but what we do when we have a kid that is in failure, we're always checking their weight to make sure that they're gaining weight. We always want them to gain about 20 to 30 grams a day. We ensure that they have adequate calories. If we need to, we increase their calories in their feeds. We obviously look for signs of reflux because usually cardiac kids have reflux symptoms as well. So then of course that, if they keep throwing up all their food all the time too, then they're not gaining weight as well. I think with them breathing really fast too, I'm sure it's not easy to digest your food. And then lots of obviously family education because these are the kids that we manage right off at home. So here's the oxygen thing. So oxygen use and defects with increased pulmonary blood flow. So O2 runs the risk of augmenting child's physiologic difficulties. It's a pulmonary vasodilator, okay? So pulmonary vascular bed relaxes and it's allowing more blood to come in, okay? So we always aim for SATs around 90 if there's a concurrent respiratory illness, okay? So our kids will have their VSDs, they will be normally saturated, but if they get an viral infection, their SATs will go down because of that, but we're okay with keeping them around 90 and above. Especially for a non-cyanotic lesion, okay? Once we get into cyanotic lesions, we'll go into those as well. Okay, so decreased pulmonary blood flow. It's our next section. Anybody got questions so far? You good? Okay. So failure to oxygenate hallmarks these defects that result in mild to severe oxygen desaturations. So these defects are obstructive to the lung blood flow or are due to embryologic failures of proper connection to the lungs. Okay? So these include pulmonary stenosis, pulmonary atresia, tetralogy of Fallot, and transposition of the great arteries. So we also have cyanotic non-ductal dependent, truncus and Ebstein's. So Ebstein's basically is the tricuspid valve is actually displaced and kind of pushed into the RV, okay? You can actually see that there's also narrowing in the pulmonary valve as well. These kids also, because of where the tricuspid valve is, these Epstein's kids have arrhythmia issues as well, or they can. Most of them have Wolff-Parkinson-White syndrome. I'm not sure if you guys know what Wolff-Parkinson-White is. So they're also at risk for potential bad rhythms as well. Okay, so you're gonna, some of these you can actually see the delta wave. If they have Wolff with this, they'll show the delta wave on the EKG. So that's another thing. If a baby gets an EKG and they see that there's a delta wave, that's another clue that we need to look a little bit further into. So cyanotic ductal dependent for pulmonary blood flow. So our critical pulmonary stenosis. So obviously that area is blocked, okay? Pulmonary atresia with intact ventricular septum. Those aren't good, okay? We want a hole somewhere. And pulmonary atresia with MAPCAs, transposition, severe tetralogy of flow, and tricuspid atresia. So these are ductal dependent. These are the ones where our duct is our friend. What is ductal dependence? So blood flow to the lungs or to the systemic circulation may be limited by structural abnormalities of the heart. Left heart obstructive lesions depend on a right to left shunt through the ductus arteriosus for systemic circulation. Everybody got that? Okay, this is always fun. Right heart obstructive lesions depend on a left to right shunt through the ductus for pulmonary circulation. Okay. So we suspect heart defect. Our initial evaluation of pre and post ductal saturations. So pre and post ductal oxygen saturations. If pre-ductal placed on the right hand, SAT is higher than post-ductal SAT, there's a differential cyanosis. So left heart abnormalities such as aortic arch hypoplasia, critical aortic stenosis, or interrupted aortic arch, because it's going systemic, okay? Persistent pulmonary hypertension. Sometimes we'll see those in our babies, in the neonates. If post-ductal SATs placed on the left hand are higher than the pre-ductal, so it's reverse differential cyanosis, those are the ones with the transposition of the great arteries, the coarctations, interrupted arch, and then pulmonary vascular resistance as well with the TGAs. Okay, so critical pulmonary stenosis. So you can see the pulmonary valve there is stenosed, or it's tight, okay? It just depends on how tight it is, if we need to do something right away. And that's obviously, we're not getting any blood right to the pulmonary arteries. We have a PFO, or a right to left shunt through the little ASD, if you guys can see at the top. Okay, and then the PDA allows flow to the PAs. Okay, so we're being able to mix, which is great, and we're still getting blood flow, but we need that PDA to be open in order to actually get blood flow to the rest of the body. So PGs, and you guys can jump in whenever you want to on your stuff. So basically, an indication for PGs are to open and maintain patency of the PDA. It causes vasodilation by the direct effect of the smooth muscle in the D8, and it works within minutes, or it's supposed to. Right? Have we had any times where it doesn't work at all? You guys? No. Okay. So usually our starting dose is 0.05 to 0.4 mics per kilo per minute. We usually try and start right at the lowest.
Yes.
And see if you get any effects, and if not, then you start titrating up.
So you'll, but the one that you came back like, well, and they didn't want to go up on it, or what was that one?
the TGA, we started at 0.05 and there was really no immediate effect.
Yep.
The neonatologist didn't want us to increase. And then about, just as we hit the city limits, the baby went apneic, so I don't know, it was just, he kind of got to that point where he was just done. It would be pretty delayed for the, and it was low dose PGs for the apnea to be blamed on the PGs because he had been on for at least an hour
Yeah.
by that point. But, so I don't know, but yeah, we didn't really see effect, but they didn't want us to go up.
Yeah.
But otherwise the SATs were
7 weeks.
okay. And the IMU was good and
Yeah.
yeah, okay.
The other fear, we talked about apnea, is transporting these kids on PGs. And I've always been told by the neonatologist that you really only see the apneic effect when you first start to eat prostaglandins. Like that kid that's sitting on bed 9, he's been on
Yes.
for how
3
long?
weeks?
3 weeks now, which is,
Almost 3, yeah.
how long can you have kids on PGs?
You can for a while.
Okay, so
Yeah.
I've never
Yeah.
seen a kid on this.
Yeah.
But if you're gonna see the apnea effect, you're gonna see within the first, what, hour of starting to
I would say, yeah.
I mean, if the kid's 3 weeks
Yeah.
without having an apnea, everyone's go, oh, we need to debate him for transport because of apneas. But if he hasn't shown apneas by 3 weeks of age, he's not gonna go apneic, unless there's another reason.
What
Or-
if you needed to increase
Yeah,
the PGs?
The
though?
potential for that,
Yeah.
the more you increase your PGs,
Yes.
there's more potential of going
Yeah.
apneic, right? So apparently we're at a good dose, that he's not going apneic, and we're actually keeping the PDA open.
But that's always gonna be a discussion when you transport these kids who are not intubated,
Mm-hmm.
on oxygen on PGs,
Yeah.
when you want to send them to Edmonton, let's say on a 3.5 hour flight, are they going to discuss whether they're going to intubate or not intubate? Just because of that risk.
Yeah.
It seems a shame to intubate a kid who's not previously been intubated, but,
It's probably
again-
gonna get intubated when it gets to Edmonton and has surgery though.
oh, for sure, for sure.
But how nice has it been for the 3 weeks to sit here, not being intubated, and have all those extra, potential complications with being
Yeah.
intubated too, right?
Don't
So,
always do it.
No, we don't always do it, it's a
Yeah.
discussion about
Yeah.
benefit versus risk, right?
yeah,
So it's not a clear cut line in the sand that you always intubate these kids when you're on PGs for transport.
mm-hmm,
It's not,
mm-hmm,
that's my point. It's a discussion now.
yeah.
It's really up to.
And I'm sure wherever you are, you're stabilizing this kid. You're going to be there for a while after starting the PGs to kind of
Yeah.
see how they're doing. If they're starting to have, struggle with breathing or whatever, then okay, yes, we should intubate and then transfer. But yeah,
Then we also we didn't talk about, kids go from here to Edmonton, not, from Thompson to
Yep.
here.
yeah.
But I guess it applies the same reasoning,
Mm-hmm.
is that it's really a discussion you need to have with your men of control.
So some rules or infusion rules. You want to infuse via a separate IV site. Is that still correct? Yeah.
Mhm.
Okay. It's compatible with D5, D10, and normal saline. It's not compatible with any other medication. Hence, I guess, why you have to have it in a separate infusion. It has a very short half-life. Okay, so you want to make sure that it's infusing well. Your IV is actually patent.
Mhm.
It's not kinked anywhere. These things happen, right? And then once the ductus is open, we try, as we're just speaking about that, use the lowest dose to optimize minimal side effects.
So, just to address this slide about, I'll address bed 9 again. I went to the bedside the other day and the nurses are going, the CVS nurse is going, they're actually stopping the PGs to give antibiotics and then starting up again.
Oh.
Which is contraindicated for PGs.
Yeah.
PGs are a continuous infusion of medications you give.
It's
And
like
you don't- and you
Norepi
don't
or
interrupt. You don't interrupt.
dopamine or, right, you don't.
And to think that when you're flushing the line, you're bolusing
Yeah.
prostaglandins.
Yeah.
So make sure that you have a dedicated IV line, whether it be peripheral or central, for these PGs, and you do not do anything to interrupt it unless it stops and goes interstitial or whatever. You don't voluntarily stop the infusion to do anything else.
Been doing that for a while.
Yeah.
On that kid?
Yeah.
Okay.
don't go back and tell me. But, I mean, but they just sent me, yeah, it was just, yeah, and that's, and then there's been another sent out about that to the, but it's begs to slide, continuous infusion, by itself, dedicated line.
Yeah.
I guess I just repeated myself, right?
No, it's
Dedicated
okay.
line and by
Yeah.
itself, but.
It's all good. So some side effects of PGs, respiratory, we just spoke about that. Cardiovascular wise, there's some, you can have some flushing or hypertension, bradycardia, and tachycardia. CNS wise, you can have irritability, jitterness, fevers, seizure-like activity. And I mean, geez, like we're having this kid on it for a long time, right? So maybe we should be looking, make sure that set of lights are being done too, because it can cause some hypocalcemia, hypoglycemia, can cause some diarrhea, and also bleeding factors as well.
Why is he on it for so long? To keep the Ductal going?
Well, right now, he's septic. He's got
I know he's on antibiotics and,
yeah.
Sorry, I just wanna,
Yeah.
say, maybe because this is being recorded, like Ainsley said, go back and erase that part about bed 9.
Oh.
Michael do that, yeah.
So yeah, those are. Sorry, your question again.
Why he's been on
Oh.
it for so long?
Mm-hmm. Yeah.
Sorry, I just